Audio, video, everything fine? Please confirm, students. Good evening, Smriti. Shall we start? Okay, thank you for confirming, Smriti. I welcome you all to the good evening, Sonali. So I welcome you all to the doubt detox session. This is our first live YouTube doubt clearing session of oral and maxillofacial surgery. I am Dr. Smriti Puri, faculty for oral and maxillofacial surgery at DAMS. So I had received a few doubts on Google Forms, and I had a few doubts on the group. So I have tried to compile those doubts. Few doubts which are remaining I'll be taking up in the next session, but the major ones which need any explanation or which need a little clarification I've taken up here. So you all can interact. You can put down your doubts if you not understood anything. If you have any cross questions, you can put them in the comment section below. All right. And along with clearing your doubts, I'll be giving a few notes, a few pointers that I would like all of you to go back and add either to your workbook or to your notes wherever you are reading your theory from. Okay, so let us start. Thank you for confirming, Sonali. Let us start, all right, with our oral and maxillofacial surgery doubt detox session. Now, coming to the first question that we have over here, all right, I want all of you to interact. You can put down your answers in the comments. Whatever you think is correct as per you. I would like to tell you, please don't be afraid. Please don't be scared of interaction or putting down the wrong answer. This is not your exam yet. Exam is a few months away. So if you make mistakes and get them corrected here, right now in the live one-on-one interaction, you will retain and remember things better. All right. So even if you do not know the correct answer, or even if you're not sure of the correct answer, please put down your answers in the comment box. I am here to correct you. I'm here to tell you how to arrive at the correct answer. This is what the session aims at, because no amount of WhatsApp chats and no amount of voice notes can clear doubts in a manner which one-on-one live sessions can clear your doubts. All right. So let us start with our first question. Absolute indication for open reduction in condylar fracture or open reduction of condylar fracture is strongly indicated in A. Condylar fracture along with body fracture, B. Lateral displacement or dislocation of the condyle, C. 20 degrees angulation, D. Condyle is separated from the stump. Okay. So now let us see what is this question specifically pointing at and what do we need to do. So the question, any one of you who wants to answer this question first? Okay, so let's see. The question is asking absolute indication. Absolute indication for ORIF of condyle. All right. When you mean absolute indication, that means you have to do a ORIF. It is strongly indicated or there is no other option. But the question is asking in which scenario only and only open reduction will be the treatment amongst the given options. Or another format of this question can be open reduction of condylar fracture is strongly indicated in. That means you have to do a open reduction internal fixation. What will be such scenarios? All right. So before coming on to the answer, there is something known as Zaid and Kent criteria, which was given by Zaid and Kent in the year 1983 for ORIF of condyle. All right. Now they gave two criteria: absolute indications and relative indications. Now absolute indications, let me zoom out. So the first one is displacement into middle cranial fossa. Alright, so if the condyle is displaced into the middle cranial fossa, only and only ORIF can retrieve it and fix it, reduce it and fix it. Okay. The second absolute indication is impossibility of obtaining occlusion by closed reduction. When you are not able to obtain occlusion by closed reduction, when the scenario is such, when the circumstances are such that closed reduction is not going to get back the occlusion for the patient. Okay. The third one is lateral extracapsular displacement. All right. So if the condylar stump is displaced laterally and there is extracapsular displacement, that means, if you remember in my theory class, I told you the glenoid fossa, the disc and the condylar head, these are intracapsular structures, or they are present within the joint capsule. All right. Now if the condyle has displaced out of that capsule, and that too laterally, okay, when the condyle has displaced outside the capsule and laterally, please remember this is very important. All right. And invasion by foreign body, or if there is any foreign body that is present in the joint capsule, okay, as a result of trauma, if any foreign body intrusion has taken place in the joint capsule. So these four are your absolute indications. All right. Next come your relative indications. That means, relative means depending on the scenario, they can be managed either by closed reduction or they will have to be managed by open reduction, depending on associated parameters or depending on the clinical picture. What are such indications? Bilateral condylar fractures in an edentulous patient without a splint, unilateral or bilateral condylar fractures where splinting cannot be accomplished for medical reasons or because physiotherapy is impossible. By splinting, they actually mean maxillomandibular fixation or IMF. Okay. Bilateral condylar fracture with comminuted midfacial fractures, prognathism or retrognathism. All right. So if the facial profile, if this occlusal skeletal, there is a skeletal malocclusion, all right, and there is a bilateral condylar fracture along with comminuted midface fractures. So in case you're able to do a closed reduction, you'll do that. In case not, then you'll go for ORIF. All right. Periodontal problems, where the periodontium is not stable enough, you can manage by both ways, where there is loss of teeth and unilateral condylar fracture with unstable base. All right. So your absolute indications are 4. Just try to remember those 4 absolute indications. The rest all become relative indications. All right. Now let's get back to our options. So option C is condylar fracture along with body fracture, B lateral displacement or dislocation of the condyle, C 20-degree angulation, and D condyle is separated from the stump. So we just now saw that lateral displacement or lateral extracapsular displacement or lateral dislocation of the condyle is an absolute indication for condylar fracture. So this is your answer. Okay. Fine. Okay. Dr. RS, ma'am, what are the sources I can prepare from except pulse? All right. I'll take this question at the end of the session. All right. I'll tell you how to prepare, how to go about your preparation at the end of the session. We'll do a 5-minute discussion regarding this. Okay. Now coming on to the next question, the second question, the treatment of mandibular fractures between incisors is by. Okay. So option A is Risdon wiring, B is Essig wiring, C is cap splint with circummandibular wiring, and D is transosseous wiring. Now this question is sort of incomplete. All right. Okay. How to decide between B and D as it is separated from the stump? So Kriti, I've come back to this question. D says it is separated from the stump, but the most important word here is lateral. This is your important deciding factor, lateral displacement. Lateral displacement. So this becomes a strong indication. This becomes a strong indication for your open reduction internal fixation. Okay. If you look at the Zaid and Kent criteria, there also the mentioned word is lateral extracapsular. This word is important. All right, Kriti, I hope the doubt is clear now. Please let me know. Coming to question number 2, the treatment of mandibular fracture between the incisors is. So now this question is a little twisted one, and you have to actually pay attention to the language that is being asked over here. So it says mandibular fracture between the incisors. So this is a symphysis fracture. All right, this is a symphysis fracture. All right, and between the incisors. So it is actually telling you that dentition is present. Dentition is present. These are the two important information or two important points that you pick up from the question. All right. So now let's see our options one by one. So the first one is Risdon wiring. We'll come to Risdon wiring later. Essig wiring. Essig wiring is actually used for dentoalveolar fractures. All right, and they are also used along with or to secure IMF. Okay. Now cap splint and circummandibular wiring is used as a closed treatment modality for pediatric fractures. Okay, and transosseous wiring is a non-rigid method of open reduction internal fixation. Okay, now Risdon wiring. Risdon wiring, the indications I have also explained in my live lectures, that the indication is symphysis fracture when entire set of teeth is present, and this gives a horizontal bracing effect. Okay, this gives a horizontal bracing effect. So that is why Risdon wiring is your correct answer over here. Fine. I hope the doubt is clear now. If there's something which is still not understood, please let me know. And Kriti, please confirm if you've understood the previous question or not. So if you see in my workbook, I have mentioned that Risdon wiring gives a horizontal bracing effect and minimally displaced symphysis fracture when all teeth are present. All right. So you have the answer to your question in your notes. Okay. Now I'd like to give you one additional tip. Whenever in doubt, whenever you're facing a doubt in a question, when you're not able to decide, especially between two options, try to go back to your workbook or your notes, all right, wherever you're reading from, wherever you're preparing from, and try to see if your notes are solving those answers. Try to match certain keywords. All right. So most of the doubts, let me tell you, most of the doubts you will be able to solve by revisiting your theory, workbook, notes, whatever. But still, if you're not able to solve them, you have to ask us and we'll tell you how to come to the correct answer between two closely related options. Okay. Now, coming to the next question, it says, after Lefort-1 osteotomy, the blood supply of maxilla is maintained by posterior superior alveolar artery, option A, B, anterior superior alveolar artery, option B, C, greater palatine artery, and D, ascending pharyngeal branch of facial artery. I want you all to have a look at a diagram here. All right. So this is your maxilla. Okay. This is your external carotid artery, and it is giving off two branches which are supplying the maxilla. Okay, students, when you're answering in the comments below, please mention the question number also, so I know which question you're answering. Okay. So now this is the external carotid artery, fine, which is giving off a branch which is known as the facial artery, and it is giving off a branch known as the ascending pharyngeal artery. Okay. Now the facial artery is giving off a branch which is known as ascending palatine artery. Okay. And these two come together to form the greater palatine artery. Fine. And further, just a moment. Okay, sorry for the interruption. So yeah, let's get back to this diagram that we were discussing. Okay, the blood supply of the maxilla, and I'll tell you why are we discussing this. And from here, this is the greater palatine artery and this is the lesser palatine artery. All right, this is the lesser palatine artery. Fine. Now, when we are osteotomizing the maxilla for a Leaford 1 osteotomy, so it can so happen, usually care is taken not to damage any blood vessel. All right, but sometimes your lesser palatine artery may have to be sacrificed. Okay, and once you have osteotomized the maxilla, now the maxilla is floating, it is mobile. You can either advance it, set it back, do a superior impaction, bring it inferiorly. So when the maxilla is a free bone, it becomes necessary that its vascularity be maintained. All right, so that it does not undergo necrosis, it does not get devitalized. Now, even if the lesser palatine artery is sacrificed, it is not going to harm the vitality or the vascularity of the maxilla to a very large extent. Okay, but what is important? This greater palatine artery, and in turn, what is forming the greater palatine artery? The ascending pharyngeal artery and the ascending palatine artery. So these arteries are forming the major part of the vascularity to the maxilla, and you, in any case, you cannot sacrifice these arteries. So when the maxilla is afloat, when it is mobile, these blood vessels are maintaining the vascularity of the maxilla. So the question is asking you, which vessel maintains the perfusion? Which vessels maintain the perfusion of the maxilla? All right. So let's come back to the question. After Leaford 1 osteotomy, the blood supply of maxilla is maintained by. So we've seen posterior superior artery is nowhere in picture, anterior superior alveolar artery is nowhere in picture. Now there is a confusion between option C and option D. C is greater palatine artery and D is ascending pharyngeal branch of facial artery. No, this is wrong. This is not a branch of facial artery. This is a branch of the external carotid artery. All right. So the correct answer here is greater palatine artery. Okay. Now, please remember, had option D been ascending pharyngeal branch of external carotid artery, then that would have been the answer. So you have to always give preference to marking ascending pharyngeal or the palatine arteries over greater palatine artery. When these two are not present in your options, then you can mark the greater palatine artery. Okay. Kriti, we try and make sure that no artery gets cut off, but sometimes the lesser palatine artery can be sacrificed because it does not form or it does not supply a major part of the maxilla. Alright, so even if the lesser palatine artery gets sacrificed, the vitality or the vascularity of the maxilla won't be compromised. It will still be intact because the major part of the vascularity is coming from the ascending palatine and ascending pharyngeal branches. Okay, so you have to make sure that your ascending palatine, ascending pharyngeal and greater palatine arteries are intact. They are not sacrificed, because if these get sacrificed, then the maxilla will undergo necrosis. Okay, fine. Alright, I have a question. Traveling log. कौन से books follow करूँ to secure government seat? 2 years, 2K rank. Alright, I just now told you sometime back we will discuss on the preparation aspect After the questions are over, I'll speak to you all for 5-7 minutes and I'll tell you the strategy for preparation. Okay. Now, I hope your doubt is clear, Kriti. Please let me know. Now coming to question number 4. In the fracture of body of mandible, the mini plate is given at A. superior border, B. lower border, C. between upper and lower border, D. none of the above. Okay. Now here, when the question is specifically asking body of mandible, alright, so we'll just discuss regarding body of mandible, and he's asking the mini plate, the positioning or the area where you will put your mini plate. Okay, so whenever there is a question regarding plating, first thing that you have to revisit is your Champy's lines of osteosynthesis. Okay, Champy's lines of osteosynthesis. Now, when it's a body fracture, alright, when it's a body fracture, according to Champy's lines of osteosynthesis, it says one plate. Body fracture says one plate, right? So let's see, superior border, let us keep this into consideration. Lower border, not possible. Between upper and lower border, let us keep this also into consideration. Option D, none of the above, not possible. So again, there arises a confusion between A, superior border, and option C, between upper and lower border. Now let us see the lines of osteosynthesis. The pink line that you see, those are your Champy's lines of osteosynthesis. Okay. Fine. So let us trace this line. In the symphysis region, up till the canine, or let's say the mental foramen, you have two plates. Okay. In the body region, you have a single plate. Okay. Angle region, there are two plates. Ideal for angle region is one plate at the external oblique ridge. Okay, one plate at the external oblique ridge. Now sometimes when, especially for angle fixation, even if you have secured a single plate on the external oblique ridge, there might be opening up of or splaying at the inferior border here. Okay, so you may need to put a second plate. Okay, and again, depending on the clinical scenario, it might be possible that a lower plate in the angle would be more efficient as compared to an upper border plate. Alright, so when you do the lower plating, then again you will have two scenarios, whether there will be a splay at the upper border or there will be no splay at the upper border. So in case there will be a splay at the upper border, you can go for the external oblique ridge plating, and if there is no splay, then well and good, your one plate is working fine for you. Okay, so these are Champy's lines of osteosynthesis. Again, for angle is one plate at external oblique ridge, and for body there is one plate. Now I am going to zoom out a little and I am going to show you. So here in the body region, this is the zone that you plate between the upper. So this is your superior border. You will never plate on the superior border. You have the teeth, you have your alveolar crest. So it is not possible to plate on the upper border. Inferior border also, if you will plate, you will achieve nothing. Alright, so the ideal plating position is between upper and lower border, but more towards the superior border in the subapical region. Subapical region. This is where you put your plate. Alright, between upper and lower border. In the subapical region towards the superior aspect of the mandible, but not the superior border. Alright, so let's get back to our answer. So option C, between upper and lower border, is the correct answer. Okay. In case this is not given, then you can mark your superior border. So C over A, if option C is not present. Not given, then superior border becomes your answer. Is it clear, all of you? Yes, Prachi, Samriddhi, you've got this answer correct. So I hope the doubt is clear. Coming to question number 5. Whitehead's varnish in gauze is used to arrest bleeding from A, gingival crest, B, bleeding from pulp, C, bleeding from bone, and D, bleeding from capillaries. Alright, so let us see. The question is asking Whitehead varnish, what are the uses? Basically, it's asking you to point out its use. So if there is bleeding from the gingival crest, you can actually use pressure. Alright, from pulp you can use either pressure or medicaments. Alright, and again, bleeding from capillaries is not high pressure bleeding. Again, you can use pressure. Alright, so the correct answer here is bleeding from bone. Alright, this is the correct answer. Now quickly, a few points regarding Whitehead's varnish. I had also told in the class the composition of Whitehead's varnish. So it is iodoform 10 grams, benzoic acid 10 grams, storax 7.5 grams, balsam of tolu 5 grams, and ether 100 ml. So the uses are, it is a medicated solution which is impregnated into a gauze to pack bony cavities. So if you remember my class on enucleation and marsupialization, I told you once you marsupialize the cavity, you can use Whitehead's varnish as a packing agent. Okay, it provides antiseptic and anti-astringent effects. Okay, the third use is helps control bleeding from raw bony surfaces or assists in hemostasis of bone bleeding, especially venous or oozing from medullary bony cavity. Alright, fine. Now there can be a variation to this question. Which of the following is used for controlling bleeding from bony surface? So here the options are bone wax, Whitehead's varnish, BIP, and cornoise. So here this answer is bone wax. This is the answer. Alright, bone wax is beeswax 70% and Vaseline 30%. Alright, so whenever they ask you regarding bleeding from bone, bone wax has to be given preference over Whitehead's varnish. Okay, please remember this point. Fine. Now coming to question number 6, muscle that aids in displacement of maxillary fracture is A, masseter, B, temporalis, C, orbicularis oculi and orbicularis oris, and D, none of the above. So masseter actually has its effect on the mandible, so does temporalis. Alright, now orbicularis oculi and orbicularis oris are muscles of facial expression. Alright, so it has no effect on displacement of the maxillary fractures. Alright, it has no effect on displacement. The maxillary fracture gets displaced primarily due to gravity and its own weight. Alright, it gets displaced due to gravity and its own weight. So the correct answer here is none of the above. Now some authors do believe, in a few places it's given that the pterygoid, especially the lateral pterygoid, does have a role in maxillary fracture displacement, but since that is not given here in the options, so it is better to mark none of the above. Alright, so you have to, what I'm trying to tell you is, you have to read your question carefully, you have to see what options are given, and that your everything has to be backed by theory. And remember, you will only be able to retain theory, you will only be able to master your theory if you are doing your questions in synchronization with your theory. So like I just told you, if you get stuck, the first thing that you do is please go and pick up your notes, your theory, and see whether reading it again leads you to the answer. Okay, and in case it does not, then we will tell you, we will guide you. Okay, now coming to question number 7. It says the most common pathognomonic sign of mandibular fracture is A. malocclusion, B. sublingual hematoma, C. deviation of jaw on opening, and D. paresthesia of mental nerve. Again, please pay attention to most common pathognomonic sign of mandibular fracture. Most common. Okay, so sublingual hematoma is the best pathognomonic sign. Alright, deviation of jaw on opening is a sign of condylar fracture. Paresthesia of mental nerve is a sign of body or parasymphysis fracture. And the most common pathognomonic sign of mandibular fracture is malocclusion. Okay, I've explained in my class also, you can go back to the app, just this particular place where I have explained most common, best pathognomonic sign, and sign always present. Please go back, go through that again, you will understand. Okay, now coming to question number 8. The optimum length of screw for fixation of plate in mandible is A. 2 mm, B. 3 mm, C. 4 mm, and D. 6 mm. Now they are asking you optimum length of screw for fixation of plate in mandible. Alright, now your most commonly used fixation plates are mini plates. Okay, and these are monocortical ones, right? They are monocortical screws which are used along with mini plates. So what you desire length of the screw which will be able to engage one cortex. Now mandible is a thick, robust bone. Okay, so a 6 mm screw. A 6 mm screw is the one which minimum 6 mm screw is required to engage the mandible one monocortically. Alright, fine, just remember this. A 2 mm, 3 mm, 4 mm screw will not be able to engage the cortex of the mandible. Okay, now coming to question number 9. In case of fracture of mandible, alveolar border experiences which force? So here basically they're asking you regarding the biomechanics of mandible in case of trauma. So when they're asking you about fracture of mandible alveolar border, that means they're talking about upper border. Upper border. Fine. So our options are A, tension, B, compression, C, torsion, and D, rotation. Fine. Now I had told you zones of tension and compression based on the relation of occlusal loading in respect to the fracture line. Okay. Apart from that, whenever we are talking about mandibular fractures, okay, and whenever we are talking about the forces, especially the occlusal forces, okay, which will be falling, the occlusal forces will be primarily affecting the superior border, okay, because that is where your teeth are present, that is where the occlusal loading is happening. Okay, now if you go to the principles of biomechanics of the mandible, what they say is, just remember this, we will not be going into too many details because this is actually a postgraduate level concept. So whenever we are studying the biomechanics, whether in regards to occlusion or not, okay, because even if the patient is not chewing, but when the patient is trying to close the mouth, trying to bite, because the occlusion is disturbed, they're trying to get back their occlusion, so there is some amount of occlusal loading always happening at the superior border. So as per the biomechanics, it is always taken as a rule that the superior border is under tension. Alright, the superior border is encountering tension or is facing tension, and the lower border is encountering compression. Okay, here also in the next diagram, so the superior border is encountering tension due to occlusal forces and it is splaying open. Okay, so one, you have to remember this, and second, you have to remember the two diagrams that I have told you in our live classes, where the zones of tension and compression, how they change as per the occlusal loading in relation to the fracture line, whether when the occlusal loading is anterior to the fracture line and when the occlusal loading is posterior to the fracture line. So please go and revise that also, and if there are any doubts, we will clear that out in the next session. Okay, so now the options that we have are A, tension, B, compression, C, torsion, and D, rotation. So the answer here is tension. Upper border, alveolar border, superior border is encountering tension. Okay, is it clear? Coming to question number 10, it says high velocity gunshot injury with periosteal denudation and comminuted fracture is best treated as A, bag of bones, B, recon plates and closure of fracture, C, immediate reconstruction and grafting, D, initial debridement is done, then load bearing reconstruction plate and grafting is done in secondary procedure. Now again, we won't go into many details, but some 2-3 points just to explain you. When there is a gunshot wound, okay, so there are 3 things that you need to take care of. First is contamination with gunpowder. Okay, 2 is loss of soft tissue. Again, this is a postgraduate topic. I'm just giving you 3-4 points. Please remember that. And loss of hard tissue, that is bony structure. Now, contamination with gunpowder, what will it lead to? It will lead to infection. Okay. Loss of soft tissue. Periosteal denudation plus loss of overlying mucosa, skin, loss of hard tissue can be loss of bone or comminution. Okay, fine. So Kriti, in the question, like I told you, your question is how to decide where the occlusal load is anterior or posterior to fracture line as tension and compression reverse. Yes, they reverse. You are absolutely correct. Until and unless it is not mentioned in the question, consider that the superior border is under tension. Alright, like I just told you, even if the patient is not eating or chewing anything, the patient is trying to occlude, because patient's occlusion is deranged. Patient is trying to occlude. Alright, fine. So as a baseline purpose, what the principles say, that it is taken as that superior border is always under tension. Now, when they mention in the question specifically that the occlusal loading is anterior or the occlusal loading is posterior, okay, so if it is posterior, then upper border becomes compression and lower border becomes tension. So you have to read the question carefully. You have to see what it is trying to ask you. If nothing is mentioned, superior border is tension always. If they have mentioned occlusal load is either anterior or posterior, then you answer accordingly. Alright, I hope your doubt is clear, Kriti. Fine, now gunshot wounds. 3 aspects I told you. Okay. Now, infection. You have to do a thorough debridement. What do you mean by thorough debridement? You have to take care or remove the gunpowder or remnants of bullets. Okay, you have to remove dead necrotic tissue and dead unviable bone. Dead unviable bone means there might be some very small bits and pieces of bone which you cannot fix, which you cannot restore, so you have to remove them. Alright, so whatever you think is not going to get revascularized or is not going to survive the soft tissue or hard tissue, you have to remove that along with thorough washout of your gunpowder or remnants of your bullets. Fine. Now there are, if you go into what recent articles say, there are 2 schools of thoughts. Some say that since there is loss of soft tissue and hard tissue involved, we do a thorough debridement and we immediately do the grafting. Okay, because later on there will be tissue contracture, there will be scar tissue, and it will be difficult to do a graft, bone graft. Okay, but some authors, this is the recent concept, alright, but what is always been held true is that in the first stage, to counteract all of this, in the first stage or immediately when the patient is wheeled in, you do a debridement. That gets your infection control. Alright, because in case if the site is infected and you do a graft, your graft is not going to take up. Okay, then in the second stage, you do the recon, either with a reconstruction plate or a bone graft, whatever. Alright, and this usually authors say that to counter scar tissue formation and contracture, the second surgery is done within 14 days of the first stage surgery. Okay, so please remember, first a thorough debridement followed by a later reconstruction. So let's see. Bag of bones is wrong. Wherever it is given, please pay attention. Reconstruction plates and closure of fracture only after debridement. So this is wrong. Immediate reconstruction and grafting, yes, can be done, but not without debridement. Alright, so the correct answer here is initial debridement and load bearing reconstruction plate and or grafting in a second stage procedure. So this is your correct answer. Okay, fine. Kriti, please let me know if your doubt is solved or not. Okay, so the next question asks, most stable in closed reduction is A, screws, B, arch wire, C, direct wiring, and D, none of the above. So screws. Here they have not mentioned whether IMF screws or mini plate screws. Alright, so this is not the correct answer. This can also be mini plate screws. Okay, it's Kirti. Alright, fine. I'll keep that in mind. Okay, now coming to this question. Now they have not mentioned whether there are IMF screws or your mini plate screws or reconstruction screws. So this is definitely not your answer. Direct wiring is an open reduction method. So this is also not your answer. And none of the above is definitely not your answer. So arch wire, when they say arch wire, that actually means arch bar plus wiring. So amongst the given options, this is your correct answer. Arch wire. This is your correct answer. Fine. Yes. 11B, Smriti, that's correct. Okay. Fine. Now, let us see. We have the last question now. An adult patient with panfacial trauma, treatment should start from, okay, or there is another variation also. Sometimes they also ask treatment should end at. Alright. Alright, start from or end at. Okay, we will now see this question. This is again a postgraduate level question. Let us first understand and then I'll tell you. Okay, now what is a panfacial fracture? Panfacial fracture is the one in which all your multiple facial bones are fractured. Let's say for example frontal bone, NOE, orbital floor, zygomatic complex. There are different Lefort levels which are present. Arch may be fractured. There might be a mid-palatal split. Palate may be fractured. The mandible would be fractured at 2 or more places, 1, 2 or 3 sites. Mandible would be fractured. So a panfacial fracture is a one in which there are multiple fractures involving the facial skeleton. Alright, that is known as a panfacial fracture. Now, when there is a panfacial fracture, you have to restore the dimensions. You have to restore the face in a three-dimensional aspect. Alright, you have to restore, you have to give back the contours, the or the form of the facial dimension, facial skeleton in a three-dimensional way. Alright, when you are talking about panfacial fractures, so you actually speak of three-dimensional restoration. Alright, and when I'm talking about three-dimensional restoration, it becomes the width, depth or projection, and height. Alright, width is this bizygomatic width, facial width. Okay, projection is this anterior-posterior projection. Some authors also call this as the depth. Okay, and this is your facial height. Okay, so you restore it in this particular order: width, projection, depth, followed by height. Alright, now an easy way to remember this is, please remember, wide, deep, harmonious faces. Alright, width, depth or projection, and height in relation to facial skeleton. Okay, remember it with this mnemonic: wide, deep, harmonious faces. Alright, now there was a gentleman whose name was Manson, and he gave the subunits principles for fixation of panfacial fractures. Alright, so he divided the face into subunits: the frontal subunit, the maxillomandibular subunit. Alright, such things he divided them into, and he gave the sequence of fixation. Okay, I'm telling you this in brief because you don't need to go into the details. This is a postgraduate level topic. Just to answer your questions, recently in AIIMS also last year 1 or 2 questions were asked, so that is why I'm telling you this. Now, he gave the sequencing. Just write down, I'll explain you. So he said that you can fix faces in 2 sequences: bottom up, that means you start from the lowermost aspect, you stabilize the maxillomandibular aspect, go up and go from inside to outside. Alright, that is, you go from medial to lateral. The other sequence he gave was top down, that means you start at the frontal region, go down and go from outside to inside, that is from lateral to the medial. This is how you fix. So what was the sequence? Palatal fracture followed by IMF or MMF, followed by condyle fracture, followed by mandible fracture, followed by condyle fracture, followed by fixation of frontal sinus, followed by naso-orbitoethmoidal complex, followed by repair of ZMC and zygomatic arches, okay, and followed by repair of maxilla or leaf foot levels, and in this also you repair the leaf foot one last. Okay, and the second one was you started from the top, that is the frontal sinus fixation, followed by repair of zygomatic-maxillary complex plus arches, followed by NOE fracture, followed by repair of leaf foot levels plus mid palatal split, that is your palatal fracture. Okay, you can come back and note down this sequence. Okay, followed by IMF or MMF, and followed by condyle, and followed by mandibular fracture. Now, when we compare these two sequences, no sequence is superior than the other. Different surgeons have different preferences. It's based on their expertise, their experience, what outcomes they have faced, what kind of fractures, how clinically the picture is. So no sequence is superior or above the other, but it is seen that this one, bottom up inside out, is most commonly followed, and there are a few studies which said that this has better functional outcomes. This is more commonly followed. It has better outcomes in terms of function, and it has better occlusal outcomes. Okay, so this is preferred. So since this is the most commonly used, we'll answer as per this. So if you see, you can start at any depending on what fracture is present where, but always end at leaf foot or maxillary levels. All right, so you start at any but end at leaf foot 1. This is the answer. Okay, this is not the answer, this is not the answer. So the confusion will always be between option A, mandible, or any and leaf foot 1. But since I told you the most common one ends at the most commonly used technique, all right, that is bottom up inside out, it ends at maxillary levels. So option D is your answer. Okay, fine. I hope with that your doubts are clear. So this is your upcoming schedule. Okay, if you are liking our sessions, please give us a thumbs up. Share this video with your friends. It's free for everyone. It's going to help everyone. Subscribe to our channel. If you still have any doubts, you can comment down your query in the comment section below. We'll get back to you with our answers. Okay, and for further queries, you can contact us on the number provided. Now, there were a few questions regarding what to prepare, how to prepare. I'll just go back to those doubts. Now, regarding books, see, it is impossible to study theory, all the theoretical books. All right, you have to, your questions, most of the questions answers you will get in your standard text. So it is impossible to study all standard text. So regarding your theory, wherever you're studying from, notes, workbook, please refer that. You have to be thorough. All right, your notes are your Bible. So once you are done with theory, you can come and do your questions from various question banks, books that are available to you, either Pulse or any other book that you want to study. Okay, also you can attempt different question banks. Suppose if your friends are having a different set of question banks, you can exchange your question bank with them, take their question bank and try to, the goal is to, rather than studying books, the goal is to try and practice as many as MCQs possible, because your MCQs are the deciding factors on the day of your exam. And let me tell you, the more you practice, the more better you will be at it. Okay. Regarding, there was a question on how to improve rank. A student who's been preparing for some time. So I would say that go back and reflect whether you are lacking in theory or you are lacking in practicing MCQs. In case you're lacking in theory, try to make notes. All right, try to make up your notes. After you have your notes compiled with you, go and start attempting your MCQs. Again, from those MCQs can be from any sources. They can be from any sources. If you are getting stuck, try to, I'm telling you the first part, the starting of how to do the revision. Once one revision is over, and how then you have to strategize after first reading I'll be telling you in the later sessions. Okay, right now we are just talking about the first first reading. All right, yes, traveling log, this is what I'm trying to tell you. When your theory, you've compiled your theory, everything you've compiled, give a good read to your theory. And traveling log especially, I will like to mention that start preparing subject wise. Let's say, for example, let's take oral surgery. You have all the notes compiled, go through them, give them a thorough reading with a good concentration without any distractions. All right, you can either read the theory, then again it depends on your comfort. Either you can read the entire theory in one go, or you can do them chapter wise. Better would be, if you are lacking or struggling, I would suggest try to, the first thing that you do is do it chapter wise. Okay, so for example, mandibular fractures, read the entire theory of mandibular fractures, go and attempt questions from whatever source you can get. All right, and when you're getting stuck, like I told you during my session, go back, see what is given in the theory and whether the theory answers your question or not. All right, so like this, you have to build upon every subject. The only thing that improves your rank is, I would recommend, is give as many as tests possible. Try to get associated with a test series. We have a test series program at DAMS also. Okay, try to attempt as many as questions. We are also having a daily quiz on our app, which is free for all. Daily quiz on Instagram, on Telegram. So try to attempt as many as questions from various sources. So in case you are struggling with a rank, I'm presuming that the theory aspect would be done, but you have to practice more and more MCQs. Yes, so that is what I'm trying to tell you. You have to see our pulse. See, as we know, the trend is changing. It is more towards clinical. You will have to clear out your concepts. Repeats have reduced to minimum, be it IIMS or your NEET exam. So that is what I try to tell you. Take up theory of every subject chapter wise. Try to understand what is given. Try to attempt questions. See what is given in the explanation of the question. All right. Do this in the first stage, traveling vlog, and then in the further sessions, I will tell you how to prepare further. All right. Because just doing one book or just doing a few set of questions, because repeats have reduced drastically over the last few years, that is not going to help. You have to do a comprehensive preparation, and that will only be possible with theory and MCQs together in the first reading, and then gradually you have to increase your number of questions per day. All right, so I think with that we will end our session. Happy studying all of you, and your doubt detox will be taken every Tuesday, Friday, subject wise. The schedule will be updated soon, so that you can join in live and get your doubts cleared one-on-one. Thank you, students. Thank you for joining in. Happy studying. Good night.